Okay, slides are visible. Okay,
Yes,
so
visible.
Thank you so much, sir. So thank you so much, Dr. Sanjay Kalra, sir, for having me for the presentation today. Like I said, in the next few slides, I'm going to discuss the cardiac arm of the metabolic syndrome, continuing with the theme on the disease of metabolic syndrome. So that is what we're going to discuss in the next few slides in the presentation. Right. So heart failure in type 2 diabetes, that's the topic we are going to discuss. Just give me 1 second. Sorry. Yeah. So heart failure in type 2 diabetes, and I'm going to, this is the broad outline of my talk. We're going to discuss heart failure and diabetes in a bi-directional link. We'll discuss what are the causes of heart failure in diabetes, and we'll also discuss the entity called diabetic cardiomyopathy. We'll also discuss how we'll recognize and diagnose heart failure in patients with diabetes. What are the pathophysiological factors leading to diabetes, leading to heart failure in diabetes patients? And we'll also discuss the management from a pathophysiological perspective, with, in the end, a special reference to SGLT2 and its role in patients with heart failure and diabetes. So that's the outline of my today's talk. So remember, heart failure and diabetes have a bi-directional link. Diabetes leads to heart failure, but it's also important that patients with heart failure are at an increased risk of developing diabetes mellitus. So there's a bi-directional link there. Not only that, there's an important concept here that we need to understand, that patients with those patients who have heart failure, the prognosis in patients with diabetes is worse. So a heart failure without diabetes is doing better than a heart failure patient with diabetes. So that's something which is very, very important to understand. And finally, a very important point which we often miss out, often in our talks, is that good glycemic control does not necessarily reduce the risk of worsening of heart failure in a diabetic patient. So that's something which is very important. In fact, there are a lot of studies which have shown that good glycemic control alone does not impact heart failure. What really does impact heart failure is the choice of the medications that we use in diabetes, especially the use of SGLT2 inhibitor, which in fact changes the outcome. And that is what we'll discuss in the upcoming slides as well. So what leads to heart failure in a diabetic patient? So we all know that a diabetic patient is at an increased risk of atherosclerosis. So you have atherosclerotic cardiovascular disease leading to heart failure in a diabetic patient. But you have very specific entities which are related to metabolic syndrome, which can lead to heart failure. So you have diabetic cardiomyopathy, which is a unique entity, which we'll discuss in the next few slides. We have hypertensive cardiomyopathy, which we all understand that hypertension, long-standing hypertension, can lead to diastolic dysfunction. And then another entity which is fast emerging to be very, very important is obesity cardiomyopathy. In fact, a lot of patients with heart failure with preserved ejection fraction, which is known as HFpEF, have heart failure secondary to obesity. And that is also an important and emerging risk factor. And that is also associated often with diabetes. Okay. So what exactly is diabetic cardiomyopathy? Now, the formal definition of diabetic cardiomyopathy is that it describes a diabetes-associated disorder, which is the structure and function of the myocardium, which are not directly attributable to confounding factors like CAD or hypertension. So you have a patient who is having heart failure just because of diabetes, right? And other causes have been ruled out. So the patient does not have a ischemic cardiomyopathy, or patient does not have a hypertensive cardiomyopathy, but rather patient has a cardiomyopathy or a heart failure secondary only to diabetes, and that is basically what is diabetic cardiomyopathy. Very interestingly, it's much more common than we imagine, and often missed out in diagnostic categorization. So how do you diagnose a patient with heart failure in your OPD and outpatient clinic? Now, as you know, renowned clinicians and as you know, a lot of people who are listening to this are well accustomed with the clinical signs and symptoms of heart failure. So I'll not you know, go into details about the clinical signs and symptoms of heart failure, but we all know when a patient walks into your clinic, walks into your OPD, the patient huffs and puffs. If the patient is having you know, dyspnea, often dyspnea with mild degree of activity, that's the patient you really are looking at heart failure, right? The patient would often come, you know, just today I had a patient who had severe bilateral pedal edema, right? Again, that is somewhere, you know, something you look at when you're discussing a heart failure. So you look at the, you know, baseline risk factors of the patient and signs and symptoms of the heart patient, but also look at the patient's ECG. You'll find features of left ventricular hypertrophy. You'll find features of left atrial enlargement. So these are all features which would suggest a potential heart failure. We all do ECG in most of our patients and most of our OPD visits. I think it's a good practice that, and remember, ECG is an extension of a clinical examination. So ECG is a must in all your patients with diabetes, because you'll often pick up some vital clues towards a diagnosis of heart failure. Now, important new development towards a diagnosis of heart failure is a very important biomarker called the NT-proBNP. Right? So NT-proBNP is a useful biomarker in your patients, and could be a good test to screen your patients for heart failure. So especially your diabetic patients where you're suspecting heart failure, NT-proBNP is a useful test. Now, NT-proBNP in a chronic patient, chronic patient with suspected chronic heart failure, the values more than 125 microgram per ml is strongly suggestive of a potential heart failure. If you're using BNP instead of NT-proBNP, then a value more than 35 is considered to be significantly higher. Now, one caveat here, remember, NT-proBNP tends to be lower in your obese patients. So if you have a patient who is obese, typically a cutoff of 100, more than 100 may be also a suitable cutoff, and such patients should be considered for further evaluation. The next step, if your NT-proBNP is higher, so when you're evaluating your patient with diabetes, we often send various tests, like for example, an HbA1c, or you might send the patient's creatinine, urine albumin creatinine ratio, and so on. One test you should add perhaps to your list of investigation is an NT-proBNP, right? So that, the patient is not unburdened with an additional needle prick from the existing blood sample. You can send an NT-proBNP, and that could be, a useful screening for your diabetic patients for heart failure. Now, if your NT-proBNP is on the higher side, you could consider sending your patient for an echocardiography. And echocardiography not only confirms the diagnosis of heart failure, but also gives you some additional phenotypical correlates. We know that heart failure with ejection fraction less than 40% is what is known as HFrEF, that is heart failure with reduced ejection fraction, and more than 50% is known as HFpEF, that is heart failure with preserved ejection fraction. And then you have the value in between, that is 40 to 49%, which is heart failure with mid-range ejection fraction. And these are all entities which are now well-established terminologies and well-established treatment algorithms as well. So hence, this is something which is useful for your patient. So what you could do is you can make a diagnosis of heart failure in patients with diabetes by using a simple biomarker, and then further evaluating with use of echocardiography. Now, in sometimes, of course, in this is a very Western approach. In India, of course, echocardiography is often cheaper than an NT-proBNP. So, perhaps you could skip the middle step also. If echocardiography is easily available in your clinic, you could perhaps send your patient directly for echocardiography also. Okay, so now let's focus on what leads to heart failure in a diabetic patient. What leads to this, entity of diabetic cardiomyopathy? Why do patients with diabetes develop heart failure? Now, there are many, many things which are culprits, potential culprits. Insulin resistance is a culprit. Autonomic neuropathy that you see in diabetic patients is a culprit. You have endothelial dysfunction, which is a problem. You have ectopic fat deposition. Like I said, we are dealing with a disorder called ectopic fatitis, which often leads to ectopic or visceral fat deposition, which leads to the various disorders like, type 2 diabetes and NAFLD or MAFLD, PCOS as well, and perhaps even heart failure also. And the role of advanced glycosylated end products also is important. Now, we'll discuss each of these points in detail, and we also tell you what are the, it's very important to understand this pathophysiology so that your treatment is more appropriate when you treat such patients, and when you understand why you're giving a particular drug to your patients. Now, let's look at how insulin resistance plays a role in that. So, insulin resistance leads to left ventricular hypertrophy, that leads to diastolic dysfunction. How does advanced glycosylated end products lead to this problem? So you have a patient with uncontrolled diabetes having AGEs. This leads to cross-linking of collagens. That leads to impaired cardiac relaxation, and also leads to diastolic dysfunction. So these are all situations how these situations lead to heart failure. But a very important and often again unrecognized entity is the role of cardiac autonomic neuropathy in patients with diabetes that leads to heart failure, or that leads to even worsening of the symptoms of heart failure. So remember, a diabetic patient, and this is very, very important, diabetic patients tend to have an increased sympathetic drive, right? Diabetic patients, remember this is rule of thumb, diabetic patients tend to have increased sympathetic stimulation or sympathetic drive. Now, we don't exactly know why. Perhaps it is a contribution of it is a part of the spectrum of the autonomic neuropathy, but this is a very well-known fact. In fact, at a baseline, your diabetic patient will have a higher heart rate than a non-diabetic patient. So that's something which is important to understand. Now, increased sympathetic drive often leads to, leads to myocardial dysfunction, can lead to increased heart rate, can lead to cardiac remodeling, but very importantly, in fact, if most importantly, leads to activation of the renin-angiotensin aldosterone pathway, the RAS pathway. The RAS pathway is activated by the cardiac autonomic symptom, and in fact, RAS pathway also contributes to cardiac remodeling and so on, right? Also, the increased sympathetic drive often puts the patient vulnerable to the risk of developing a sudden cardiac death also. So these are all things which are associated with cardiac autonomic neuropathy. How does endothelial dysfunction lead to diabetes? Now, diabetes, apart from being a disease of ectopic fatitis, it's also a disease which is a extremely vascular disorder, right? And the vascular aspects of diabetes is often contributed towards by the endothelial dysfunction aspect of diabetes. Now, the advanced glycosylated end products, which we just discussed, often reduce the nitric oxide release. And this reduction of nitric oxide, remember, nitric oxide leads to vascular dilatation. So this reduction of the nitric oxide leads to poor vasodilator response. So you remember, when your heart requires more blood, requires more vasodilatation, and this vasodilatation often leads to improve of the cardiac blood flow. But this ability is reduced in patients with diabetes, especially smaller epicardial blood vessels fail to supply blood to the heart in the situations of stress or in critical situations, and often that leads to myocardial ischemia or infarction. Then you have ectopic fat deposition, and this ectopic fat deposition also contributes to heart failure. Especially, it contributes to the heart failure with preserved ejection fraction. If you see this picture here, you have the visceral pericardium and the peripheral pericardium, and here this is where you have the epicardial fat which is being deposited. You also have the pericardial fat. So you have the ectopic, the epicardial and pericardial fat. These levels are increased in patients with diabetes. In fact, there's also increase in patients with obesity. So certain patients with obesity also tend to have increased ectopic and pericardial fat, and that contributes to the heart failure with preserved ejection fraction, and that is again something which is important to understand from a pathophysiological perspective. So, what could be the potential strategies for management of heart failure? Now we understood the pathophysiology. What could we do to correct the problem which we see? So, of course, we can reduce the cardiac sympathetic drive, right? We could curtail the RAS activation which is seen. You could reduce the ectopic and pericardial fat that we saw. You could reduce the advanced glycosylated end products, and you could correct the endothelial dysfunction. And of course, one more point, you should reduce insulin resistance. So these are all things which are potential strategies which you could apply for your patients to reduce the risk or reduce worsening of heart failure. Okay, so what could we do for each of these? So to reduce the cardiac sympathetic drive, you could use beta blockers, and a very good beta blocker to use in such situation. A very good beta blocker to use in such situation is carvedilol, right? We know carvedilol is an ideal beta blocker to be used in patients with diabetes and heart failure. You could curtail the RAS activation. So the RAS activation pathway, you could use the drugs which are acting on this pathway, like your ACE inhibitors or ARBs, your MR receptor antagonist, like your spironolactone, or you have now ARNI, which is also available. And I think another drug which falls into this category is Finrenan, right? So these are all drugs which you can use to curtail the RAS activation pathway, and hence these are very important drugs to be used for patients with heart failure. You could reduce the epicardial and pericardial fat, and remember one drug which is that's why it's very important to understand the spectrum of today's discussion, right? One drug which is commonly used in a lot of these patients is an SGLT2 inhibitor. SGLT2 inhibitor controls the epicardial and pericardial fat. It reduces the fat, epicardial and pericardial fat, also reduces the fat in the liver. So that we already saw from the earlier lecture. So that's something which is very important, right? How do you reduce, AGE and endothelial dysfunction? This could be helped by good glycemic control. So good glycemic control really is something which is helpful here. And apart from this, of course, we discussed that you reduce the insulin resistance, which can be done with the use of, good lifestyle measures, weight reduction, SGLT2, and also metformin. So these are drugs which you can use to reduce the insulin resistance. So all this combination, in effect, would improve the outcome in your patients with heart failure and diabetes. Now, so we discussed how you manage heart failure in a patient with diabetes. But let's discuss how you'll manage diabetes in a patient with heart failure. So if you have a patient with diabetes and heart failure, there are some medications which you should use. There are some medications which are neutral, and there are some medications that you need to avoid. Now, medications that you should definitely consider using, SGLT2 is a must in these patients. You could use GLP-1 receptor agonists in certain situations where SGLT2 may be contraindicated or may not be effective. which are drugs which are neutral. So you could consider using metformin. It's a neutral drug. It neither worsens heart failure nor it has any direct benefit, but maybe indirect benefit through insulin resistance. We know that. You could use DPP-4 inhibitors with proven heart failure safety, like sitagliptin or linagliptin, or you could use other drugs like AGI and so on. And you can use, of course, sulfonylurea, but again, heart failure safety is now established there. But medications that you need to avoid is pioglitazone and DPP-4 inhibitors with potential heart failure precipitation like saxagliptin. These are drugs perhaps you need to avoid in these situations, especially patients with heart failure situation. Right? Okay, so like Dr. Kalra sir said, we dwell a little bit into technology, and we are trying to create a platform called diabetology.co.in, which is a precision medicine algorithm for patients for physicians to identify the right treatment for your right patient. And you have, when we are creating this algorithm, we recognize that one very, very important piece of the puzzle is actually heart failure, right? So, you need to, when you fill up this form, right, this is freely available to you. So if you go to diabetology.co.in, you can go to diabetology.co.in website, and you go to the website, there is something called, in the very top, you will have a first prototype. So click on that. This will open this page for you. So let's enter some sample data for this patient and let's see what treatment is generated by the algorithm. And the answer will not be surprising to you. So enter the age of the patient, you enter the gender of the patient, enter all the other clinical data. So you enter subclinical data. So I pre-filled this but most importantly, of course, there's a section here which asks you to fill whether the patient has an evidence of heart failure, and that's again your clinical diagnosis. So if you say yes to it, we'll proceed further, and then you enter the other data. So in this patient, we have entered the data. Patient's BMI weight is 102, height is 180, so BMI is 31. So this is an obese patient, right? We have entered the triglyceride, the HDL, the LDL levels. The patient's fasting blood sugar is 150, post meal is 202, HbA1c is 8.4. You can skip the C-peptide values if they are not available. Let's say this patient has a creatinine of 1.6 and a urine albumin creatinine ratio. Let's increase that a little. It says 45. Let's increase it to, let's say, something like 102. Potassium, let's say, is normal. Let's say the patient is coming from a low income setup. Patient is open to taking injectables. There's no problem with pill burden. His heaviest meal of the day is lunch and does not have any shift duties, right? So then you click on the recommendation, and this is what it will give you, right? So it gives you, it first gives you a cluster classification. So this patient is the best fitted into cluster 2, that is insulin resistant obese diabetic. This patient at this point of time does not need insulin. The patient's eGFR is 49 and falls into diabetic kidney disease category of Q3A2. The patient is definitely a candidate for Finrenone therapy also, but of course, patient has, cost is an issue for the patient, so maybe, may or may not be able to afford it. Let's look at the statin use. The patient requires high intensity statin, rosuvastatin 20 to 40 or Atora 40 to 80 you could use, and with the LDL target of 67, perhaps even lower. The patient is not a candidate for it could be a potential candidate for diabetes remission, barring the heart failure issue. Remember, the patient has heart failure, so perhaps age of 60, so a slightly liberal target of HbA1c of 7.5 may be okay. And then let's look at the medications which the patient could be given, right? So this is the list of the medications. So patient could be a candidate for Finrenone, atorvastatin 40 milligram, telmisartan. Remember, ACE inhibitor ARBs are very important here. Metformin could be given, here, and dapagliflozin, right? So no bias here, but you can see, the algorithm came up with this treatment because the patient has heart failure, and hence, that is something which you could use. Again, you can see the explanation also why each of these drugs has been prescribed in this patient, right? So you could use algorithm like this, and you'll find that a lot of these algorithms will come up with the treatment. There are some drugs which are extremely essential in such situations. You can clearly see, and that is, like SGLT2. Right. So now let's dwell a little bit more into why SGLT2 is very important, right? In a patient with heart failure, in fact, with or without diabetes mellitus, SGLT2 is now a cornerstone of heart failure management. So it is backed by data, it is backed by guidelines, and also pathophysiologically point of view, it makes sense. So we'll see each of these points in a little bit more detail. Now, as far as the data is concerned, I think we are already bombarded with extreme amount of data on SGLT2 in heart failure. I think there is undoubtedly a good use, but I think I just want to show you one visual memory for you. So this is a study where they compared SGLT2 with sitagliptin. in terms of heart failure hospitalization. And you can see very clearly, look at this Kaplan-Meier survival curve, separating in terms of incidence of heart failure precipitation, right? You can very clearly see, in fact, within days of starting these drugs, there is a clearly divergence of the right. So clearly, patients on saxagliptin they're more likely to be admitted for heart failure hospitalization compared to a patient on SGLT2 inhibitor. In fact, the incidence is much lower even after almost a year of therapy. So that is something which is very remarkable and statistically significant also. What do the guidelines say? So if you see the guidelines, if you see the, for example, ESC guideline for heart failure management, I'm not even talking about diabetes, I'm talking about heart failure in general. They say these drugs should be part of heart failure management: ACE inhibitor, ARB or ARNI, beta blockers, MRA, DEPA or empagliflozin, and loop diuretics for fluid reduction. And then, of course, for the treatment is depending on the heart failure for the algorithm-based treatment. Okay, what about pathophysiology? Now, how does SGLT2 make sense from a pathophysiological perspective? So there are many reasons why SGLT2 works, and we already discussed the pathophysiology of heart failure and how SGLT2 contributes to that, but also let's look at that in more detail. So, of course, diabetes and heart failure, you have endothelial dysfunction and insulin resistance. Now, endothelial dysfunction often improves with improvement of glycemic control and reduction of AGE, but insulin resistance can also be reduced with the use of SGLT2 inhibitor and metformin. So using a combination of metformin and SGLT2 often reduces the insulin resistance. Then, of course, SGLT2 directly has some mechanistic benefits towards heart failure. It has some mild diuretic effect because of natriuresis and glucosuria, and because of that, the patient often has improvement in terms of clinical symptoms also. So, in fact, we often say we want to improve the quality of life of our patient. In a patient with heart failure with diabetes, giving SGLT2 almost immediately improves the clinical symptoms and the quality of life of the patient. There are some metabolic benefits also. There is increase of glucagon and increased ketone body utilization. Now, the interesting thing is that using of ketone bodies in such situation, what it does is it improves the efficiency of the cardiac muscles, and hence, with a lower fuel, it can do a better job. So in that situation, in an ischemic situation also, use of ketone bodies is something which could be helpful, and in fact, it has a cardioprotective effect. And overall, there are certain other cardiovascular benefits of SGLT2 that are independent of glucose level also. So it could be potentially independent benefits also. There are in fact a lot of benefits which you don't even understand. And one benefit, like I told you, it reduces the ectopic and pericardial fat, epicardial and pericardial fat also in such patients, leading to improved cardiac output. So overall, this was my presentation. We have some interesting developments in the field of technology and endocrinology, and we have developed this Endo AI app, and like Dr. Kala sir said, we are now integrated. We are soon integrating with EndoText, so you can search for questions to answers to your question on diabetes and endocrinology. Looking at this, we have a notes in endocrinology app, and we are working on a precision medicine algorithm for diabetic patients called diabetology.co.in. Preview of which I showed you in this presentation. So thank you for a patient listening, and I hope this was useful, and I'm sure we'll be having some questions at the end with the rest of the presentation.